Welcome back. This chat today will be on history taking. The first four chats have been on retinal anatomy and the color of different retinal lesions. So when you're talking to your colleagues and explaining what you were seeing, you have an idea of giving a picture to the colleague of what you are seeing. Now, while a lot of retina can be pattern recognition, history taking is also incredibly important. You'll find out while you're in the retina clinic, or if you do choose to go into retina, you will find people referred to you because their vision is not 20/20 and there's no cataract. And you'll be making many, many different diagnoses, and a lot of this will be based on the history. In my career, I have made diagnoses of monofixational syndrome, convergence insufficiency, pituitary tumors and strokes, carotid stenosis, as well as subtle nuclear sclerosis. So the diagnoses that you'll be encountering are incredibly varied, and many times this is based on the history. So you're already familiar with the basic history that you want to take from a patient. A patient comes in with right lower quadrant pain, it's sharp, it's getting worse, associated with some nausea, rebound tenderness. You're well on your way to making a diagnosis of acute appendicitis. So I'd like to go into the different styles of the symptoms for a patient with retinal disease. And these obviously are: where is the visual blur? Where's the location? What's the quality, duration, progression, severity, modifying factors, and associated signs and symptoms? And we'll go into each of these in detail because eyes and the symptoms are quite specific and different from the rest of the body. So, location of the visual complaint. And you want to know, is the complaint right eye, left eye, or both eyes? Is the complaint in the middle of the vision, or is it peripheral? Is it to the side on the right, side on the left? And do they notice this in the upper or the lower field of vision? Now, some people come in and they'll say, well, I've had blurred vision for a right smart time. And they don't know if it's the right eye or left eye because they have not closed one eye or the other. Sometimes patients will say, I went blind in my left eye, when they actually had a right cerebral infarct and the left visual field is blurred, and they think that the left eye sees to the left and the right eye sees to the right. So in the history, you want to see if you can find out where the blur is. Different diseases will give different spots in a particular eye, whether it's in the central vision or the peripheral. Sometimes they can't quite say, but they may say, I'm bumping into doors on my right-hand side, and that gives you an idea that the vision to the side is down. I've had several people come in and say, well, when I'm driving, I can see the car in front of me, but I can't see the signs up front, up top. I can't see the signs. I can't see the streetlights. That gives you an idea that is the upper field of vision, and that may lead to a different diagnosis. Or sometimes people say, I'm having trouble walking down the stairs, and you know that they have an inferior defect. So these are the main locations and some questions of how to get out from the patient where they're noticing and how they're noticing the changes. Now we want to talk about the quality of the visual complaint. And in different chats, we'll go into all of these in more detail. Some of the more common complaints that you will run into on the retina surface will be patients coming in with floaters and light flashes. Now, the most common association will be with a posterior vitreous detachment, and you'll have to rule out a retinal tear or a retinal detachment. About the floaters, you want to know, are they large, are they small? Do you have one or two, or do you have thousands? If there's one or two, most likely it's a vitreous detachment without a tear. If there are thousands of floaters, you have to be very, very careful it's not inflammation or blood or retinal tear. Some people say, well, I have blurred vision. Well, what do you mean by blurred vision? Is there a smudge? Is there a distortion? Are pieces of the jigsaw puzzle missing? Are the images different sizes? So these are the different symptoms that patients may not be able to come up with the right wording on their own, but these are ones you can suggest for them. And sometimes they'll say, well, I've got a shadow or a curtain or a cloud in my field of vision. And so you want to know, is it right, left, up, or down? Is it absolute, or can they see through it? So these are the questions you want to ask about the quality of the patient's symptoms. Well, next you want to know, other than you have these symptoms, you want to know for how long have you had the symptoms? And the important question is, how did you notice the visual change? Now, some people say, well, I went blind in my right eye yesterday. Well, how did you notice it? Well, I was lying in bed and the pillow was covering my left eye and I couldn't read the clock with my right eye. Well, if the patient could have been losing vision for a long time in the right eye, brain doesn't like blurred vision, it'll ignore it, they will concentrate with a good left eye, and all of a sudden they accidentally cover one eye and they find they do indeed have a problem with one eye. Sometimes they just really don't know what the duration is because some diseases will creep up very slowly. And say, well, it's been 6 months, 9 months, I don't quite know. But then you want to know, well, what was the final symptom that came and led you to come in at this visit and try to get a history in that fashion. The progression of the visual symptoms are really important. You do want to know, is there a sudden onset or is it a gradual onset? And then what's the progression? Is it a slow gradual as the arrow on the left? Was the vision good, a sudden drop for about 4 or 5 months ago and has leveled off? Or did the vision get worse and now they're coming in a recovery phase? Unfortunately, there are times that I will see people after cataract surgery and they don't see well. And in the history, well, what happened? Well, about 4 months ago, I had a sudden vision loss. I went in, they told me I had a cataract. They took it out, but I can't see. Well, the problem is the sudden vision loss 4 or 5 months ago was either an artery or vein occlusion or a macular degeneration that was masked by the cataract, and the cataract was taken out, and then that unmasks the problem in the back. So you wanted to figure out what is the progression. Many times I'll use my hand to show a gradual decline or a drop and then leveling off, and sometimes the combination of the speech and a visual helps people understand their own course of their disease. Now, severity is important for a whole variety of reasons. If you're going to do elective surgery, you want to know, how bad is this problem? If someone has an epiretinal membrane or a macular pucker and they come in and the vision is blurred, you can do surgery, but you want to make sure that you are actually positively affecting the patient's life if you're going to do the surgery. So some people have no idea of how much it bothers them. So I give out different ways for them to describe it. It can be either mild, moderate, or severe, or for your activities of daily living on a scale of 1 to 10, how bad is it? 1, okay, I get a blur, I don't care. 10 is driving me crazy. Well, that's a really good idea. Then they can figure out, that's it. And then give them choices. Does it affect your reading? Does it affect your driving? Does it affect the television? Do 6s look like 8s? Do 1s look like 7s, especially if they are bookkeepers? And give them an idea. How much does the visual blur and symptoms bother them? And that'll give you a really good idea of the severity. Now you want to know what are some of the modifying factors. When do you notice the blur the most? It can be indoors or out of doors, nighttime, during the daylight. Is it worse for reading? Is it worse for driving? Is it worse for television? And so you can get an idea of not only how the visual blur bothers the patient, but under what circumstances. And then finally, you want to know, are there any other associated signs and symptoms? Pain, either in the eye, headaches, or is there pain on eye movement? If there's pain with a foreign body sensation, that could be strictly a cornea problem. Are they photophobic? Does the sunlight really bother them and you're going to lead down towards an inflammatory process? Dull or sharp pain? Now, many people complain of a sharp stabbing pain, and that is very bothersome, but it's not dangerous. Dull, achy pain, now you're into anything from a uveitis to a chronic glaucoma to a scleritis, orbital inflammatory disease. There are many different things. So you want to try to distinguish when they talk about pain, what kind of pain. Obviously, headaches are important because you will find people with cranial arteritis or pituitary tumors or aneurysms. So you want to know, are there other headaches associated with the visual blur? Then finally, you will also be seeing patients with orbital inflammation of different styles or an optic neuritis, and you want to know whether there's pain on eye movement. Is there anything that can make the pain better, or is there anything to make it worse? So in summary, all aspects of the history are really important. Some patients you may want to stress one and some on the other. But in giving the history and asking questions, though, be sure that you give options. Don't lead the patient. Don't say, oh, is it getting worse? Is it more at nighttime? Because they may feel like you're asking certain questions. You say, is it getting worse or is it getting better? Is it worse at nighttime or is it worse during the day? Has it been going on for a long time or a short time? So that way they don't know which way you're going and they will be giving you a more honest answer. So even though, again, much of retina is pattern recognition, the history also is extremely important, and please don't shortcut the whole examination by taking too short of a history.